Abdominal assessment. This can be quite tricky in a sedated, intubated patient. The key is to establish your baseline assessment and be alert to deviations from that, whilst gaining cues from your full A to E toolkit. Abdominal assessment has a strict order: look, listen, and then feel. Changing the order can alter the frequency of bowel sounds and affect the accuracy of your assessment. Look at the abdomen. Look at the shape. Is it flat, rounded, or distended? Is it normal for the patient? Look for the presence of any masses, hernias, ascites, prominent veins, bruising, scars, drains, or stomas. Look at gastric aspirate, volumes, or colour. Listen for bowel sounds. Place your stethoscope over the right lower quadrant and listen for 1 full minute. If absent, listen to the right upper, left upper, and then left lower quadrants to try to identify bowel sounds. If present, are bowel sounds active? You would hear gurgling every 5 to 10 seconds. Hyperactive, more gurgling within that time, and that can indicate early obstruction. Or are they completely absent, indicating ileus? Now feel. Is the abdomen soft or firm? Look again for distension, but note any increase in respiratory rate or heart rate during assessment, as this may indicate pain. And look for guarding, involuntary contraction. Bowels. Check the last documented bowel action. ICU patients often have reduced bowel motility and are at increased risk of constipation, defined as no bowel action within 72 hours of admission to ICU. This can impact adversely on length of stay. Give prescribed aperients. These are commenced early in ICU to promote regular bowel actions, ideally aiming for a 2 to 5 on the Bristol stool chart. There should be a local policy or bowel protocol to follow. Follow it. Promote dignity with incontinence and be mindful of positioning. Consider using a hoist to assist with a more natural defecation position in those patients who are more awake. Record frequency and consistency. Uncontrollable diarrhea is a pressure and positioning risk. Flexi-seal tubes or rectal tubes may be used to protect skin and measure fluid loss. Venous thromboembolism or VTE. Use your risk assessment as per your local hospital policy. All patients should have Flowtron or TED stockings in situ unless this is not possible due to, for example, leg ulcers. ICU patients are most likely to use intermittent compression boots such as Flowtron to stimulate the flow of blood to the deep veins and help prevent thrombosis. Remove Flowtrons and/or TED stockings once per shift to inspect the underlying skin. Vasopressors and immobility increase the risk of hidden pressure sores. Give antithrombolytic prophylaxis treatment according to your local policy. General cares. Regular mouth care is provided for patient comfort and to assist in the prevention of ventilator-associated pneumonia. Look for any ulceration, gum bleeding, or loose teeth. Toothpaste and baby toothbrushes are used twice a day. Water is used at least every 4 hours with Vaseline applied to lips each time. For some patients, mouth care may not be appropriate and will be performed only at the direction of the ICU nurse. With eye care, it is very important to understand that sedated patients are unable to blink. This puts them at risk of corneal sores. Do not underestimate the importance of moistening. Check both eyes for dryness, redness, scleroderma and pus. Use sterile water and gauze to gently clean eyes from inside corner to outside. Eye drops and Lacrolube may be used in line with local policy. Proned patients who will be receiving muscle relaxants will have their eyes cleaned and protected with taped gauze. Sedated patients are unable to move independently. Patients are completely dependent on the bedside team to promote cleanliness and prevent complications. Circulatory collapse and vasoactive medication increases the risk of pressure sores. A pressure breakdown risk screening must be undertaken and recorded with a tool such as Waterlow. Look for any skin breakdown, redness, blistering, surgical sites and existing pressure sores, wounds, dressings and rashes. Check all medical devices for signs of medical device-related pressure sores. Record the type of mattress currently used and check the mattress is functioning properly. Check that the NG tube is not rubbing nostrils. Check peripheral and invasive line sites for signs of infection. Check the ET tube and holders by regular repositioning or using pressure alleviating devices such as an anchor fast. Check when ET tapes, if present, were last changed. Change the saturation probe position a minimum of 2 hourly. Ensure any lines and drains and catheters are not lying underneath the patient. Check under dressings and check under the patient. Coordinate turns and washes with your buddies. Minimise shear and friction damage with correct use of manual handling assists and sliding sheets. Pay particular attention to bed sheets and pad creases after repositioning, as, if present, they may cause pain and contribute to sores. And document the presence of any pressure sores according to the local hospital reporting systems. But remember, you are part of a team. Use other multidisciplinary team members, for example, tissue viability, speech and language, physiotherapy and medical photography for advice and assistance. Everybody is happy to help.